In the next 15 minutes, I will give an overview on therapeutic interventional endoscopic ultrasound indications and techniques. So these are my disclosures. So interventional EUS, I would say that this is rather a young endoscopic subdiscipline. The first fine needle aspiration was already performed in 1992, so 30 years ago. But you see that the first EUS-guided bile duct drainage was only performed in 2001. And then the lumen-opposing metal stents, which we now use quite often for off-label and in-label indications, were only introduced in 2012. I have the impression that we have also a gradual movement towards vascular interventions, and you see that the first EUS-guided portal pressure measurement, for example, was performed in 2018. So what are the current possibilities of the interventional EUS? We have a possibility to drain peripancreatic collections. We are able to perform an EUS-guided bile duct or pancreatic duct drainage. We can do a gallbladder drainage. We are able to create connections between different parts of the digestive tract. And this includes a gastrogastrostomy, for example, in gastric bypass patients to facilitate ERCP or to have a look in the excluded stomach, but also creation of a GIEQs in patients with gastric outlet obstruction or a GIEQs depending on the clinical presentation. Of course, we can do the celiac plexus block already for a while. We can place fiducials to help radiotherapists to perform their radiotherapy in certain indications. Radiofrequency ablation is also a possibility that has recently been introduced. And then, as I said, there are a number of vascular interventions that we are able to perform, like coiling or glue injection and the portal pressure measurements. Let's move to the EUS-guided bile duct drainage. There are two ways to perform a direct EUS-guided drainage of the biliary tract. We can create a connection between the duodenum, mostly the first part of the duodenum, and the common bile duct. This is called a choledochoduodeноstomy, and the main indication here is a tumoral distal bile duct obstruction. The other technique is a hepaticojejunostomy, where you make a connection between the stomach, mainly the upper part of the stomach, and the left lobe of the liver. And this can be performed in case of a tumoral bile duct obstruction. It can be both a proximal obstruction, where you have preserved left-right communication, or a distal bile duct obstruction. And more, it's also used to create an access to the bile ducts in case the patient has an altered anatomy, such as, for example, a Whipple procedure. Very interesting paper was published in 2018. I will just show you this paper because I believe that there might be a paradigm shift over the next few years. So this study looked at 134 patients, all with unresectable malignant bile duct obstruction, and the patients were randomized into a group that received the classical way of drainage with ERCP first versus an EUS-guided transmural stenting using one of the two techniques that I've discussed in my previous slides. So what did the study show? The study showed that the technical success and the clinical success were similar, whether you used ERCP or an EUS-guided drainage, although the adverse events were much higher in the group that received ERCP. And this was mainly because there were quite a lot of patients suffering from pancreatitis after the ERCP, while with an EUS-guided drainage, of course, you do not touch the pancreatic orifice. You just bypass the obstruction. And so this is a very important result of the study, because I personally believe that in the future we might have this EUS-guided drainage as a first-line therapy for patients with this malignant distal bile duct obstruction that cannot be operated.
For same procedure ESCP, and that's step 4, we perform balloon dilation so that we can safely and also very cautiously pass through the lumen opposing metal stent. There have been some studies proposing anchoring techniques by clipping or suturing, but I guess the conclusive evidence is still not really there. The main message is to be very, very careful here and use a combination of careful advancement and also fluoroscopic control to prevent LAMS migration, because that's a disaster in these benign patients. So when we're done with our ESCP, we carefully come back. You see there the sphincterotomy, and then we come back in the remnant gastric stomach, and this is the moment you really have to make sure that your scope is in a neutral position and careful wiggle your way out of the lumen opposing metal stent. And you see here we're passing the stent, carefully retracting it, constantly checking the fluoroscopy, and then we're in the gastric pouch again. That's the Z line you see there, and then we're in the pouch. So what's the evidence? Recently there was a large retrospective multicenter study published showing that 50 millimeter LAMS is an independent risk factor for LAMS migration. It was only, I think, published a couple of months ago. And I think this is one of the most important retrospective studies to date. Just suggests that you should use 20 millimeter LAMS to prevent migration. There have been some pooled analysis as well, showing high technical success in endoscopy this year. And also there have been some comparisons with laparoscopy-assisted ESCP versus EDGE versus enteroscopy-assisted ESCP. And the general consensus is that technical success is similar when comparing EDGE to laparoscopy-assisted ESCP, but that EDGE holds a higher efficacy when compared to enteroscopy-assisted ESCP at the cost of a slight increase of adverse events. To date, there are still not randomized controlled trials ongoing for EDGE, to my knowledge, so that's perhaps something we can work on together. And one of the most important points to close off my talk is to say that we should really work together to make sure that this prospective confirmation is sought and that we can file for reimbursement and can make sure that every patient who requires it can undergo these procedures in the near future and can keep on receiving these procedures.
Okay. All right.
Yes.
Hello.
Hello.
Good morning, everyone. Once again from the EOS ERCP room. We already started the procedure. That is, we introduced the scope and had a quick look around.
Okay.
And on the EOS image, you see the left liver lobe, obviously. With severely dilated intrahepatic bile ducts, joining here towards the hilum. And the idea is now to create a hepaticojejunostomy, which I think is a perfect candidate for a procedure like that. And what we do is from the stomach, like I said, to the left liver lobe. And what you see there are basically segments 2 and 3. It's very hard to discriminate between the two based on EOS, but to remember is that segment 2 is the higher one, segment 3 is the lower one, and it's better to go for segment 3 than for segment 2. For segment 3, you're sometimes very close to the esophagus, and that gives problems both with deployment, but also with sometimes even obstruction. Although typically the route is a little bit easier coming from 2 than 3. Try to aim for segment 3.